I'm gonna be streaming this live on YouTube as well. Getting ready to start that. Sherry, you ready for with the poll and everything and all that? Be streaming this live on.
Yeah, did you want one for each showcase?
Yep.
Okay.
Folks, we're just put on YouTube live. We're just about to get started. All right, Paresh, if you're ready to go, I'm ready to go.
Okay, let's go on.
All right, 3, 2, and hello, everyone. This is Eric Glazer, and this is our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We're recording live with our very special guest, Dr. Paresh Dandona. A very friendly hello to our regulars and a very special welcome to those of you joining us for the first time. If you are new to us, we focus our programming on not only informing our audience, but most importantly, unearthing the bright spots or the successes at health plans, hospitals, and various other healthcare organizations around our country. Our goal is to identify as many bright spots as possible so that you, the listener and the audience, can determine if these ideas shared with you today are able to be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. Our topic today is rethinking diabetes management and how some of the different calculated approaches to supporting the chronically ill can make a huge impact in improving clinical outcomes and economic effects of a healthcare and population health program. A little bit about our special guest. I typically am pretty good at distilling down the bios of our guests, but kind of like trying to get the Beatles' greatest hits down to 5 songs. It's nearly impossible. So bear with me. I'm even going to attempt to pronounce some really tough words for me. So I want you to hear a little bit about what the value you're about to receive. Our guest today is Dr. Paresh Dandona, who is both a medical doctor and a medical doctorate and a PhD. He is the SUNY Distinguished Professor of Medicine and the ex-chief of the Division of Endocrinology, Diabetes, and Metabolism at the University of Buffalo. He is the founder and director of the Diabetes Endocrinology Center of Western New York. And he is a Rhodes Scholar from India, trained at the University of Oxford and the University of London. He received the Endocrine Society Award for the discovery of the anti-inflammatory effect of insulin. This discovery has been extended into other potential cardioprotective and neuroprotective effects of insulin in acute myocardial infarction, stroke, and Alzheimer's disease. He also works on obesity, oxidative stress and inflammation, and the pro-inflammatory effects of macronutrients, and is now which is all now recognized globally. He has also demonstrated that the most common cause of male hypogonadism and potential infertility is low testosterone in males with type 2 diabetes and obesity. And consistent with this, his research has shown that testosterone reverses type 2 diabetes in 1/3 of such patients. He has recently been awarded the largest grant ever from the Juvenile Diabetes Research Foundation to investigate the effect of triple therapy, which includes, bear with me here, insulin, semaglutide, and dapagliflozin. I think I got that, Paresh. I know it's not great. I know all the practitioners in the audience are rolling their eyes. In patients with type 1 diabetes, he is pioneering his work. His pioneering work has led to the licensing of the aforementioned pharmaceutical dapagliflozin as the first oral therapy for type 1 diabetes in all of Europe and Japan. His awards are way too many to list from all over the world. He has published more than 600 publications in peer-reviewed journals. He is the founding editor of Metabolic Syndrome and Related Disorders and is or has been on the editorial boards of the Journal of Clinical Endocrinology and Metabolism, Diabetes Care, Current Diabetes Reviews, and the Journal of Diabetes and Andrology. Wow. All right, welcome Paresh Dandona to Bright Spots in Healthcare. So, Paresh, let's start with some stage setting on diabetes and the inherent challenges in treatment. And then we'll move on to innovations that you see in the space, and then we'll cover the more ins and outs of your own CDE program and the impact that's making. And then if we have time, we'll take questions from all the folks watching and listening live. Does that sound okay?
Yeah, that's fine.
Great. All right. So we know there are 30 million diabetics in the US alone, correct me if I'm wrong, and that diabetes is the single most important cause of adult kidney failure, blindness, amputation, and nerve disease, and also enhances death by heart attack, stroke, and now COVID-19. And only about 50% of the patients have their diabetes controlled. So with all that as background, what are the implications of good control or bad control of individuals with diabetes?
So this has been a challenge ever since I started training way back in 1975 as to whether good control matters. And now, without any doubt, it's been clearly established, starting with the DCCT study in type 1 diabetics, where a 2% reduction in A1C led to 2/3 reduction in the frequency of complications. And the complications that you mentioned already are the ones that are involved, which are blindness due to retinopathy, neuropathy, and nephropathy, which is kidney disease. And 50% of end-stage kidney failure today is accounted for by diabetes. So all of this was shown to be reduced by the DCCT study. And then came the Kumamoto study from Japan in type 2 diabetics, similar reduction in A1C by around 2%, and a very similar frequency of reduction in complications. And then came the big study of UKPDS from Britain, based in Oxford, run by two of my old friends, and showed that 1% reduction in A1C led to 33% reduction in the complications that we've talked about. So now there is no doubt at all that good control makes a difference, and therefore we need to commit ourselves to that, because diabetes itself leads to misery if it's got complications. And of course, today it costs the nation $330 billion per annum, which is about 1 in 4 healthcare dollars is dedicated to diabetes and its management. So we need something at both fronts. Reduce the misery of the patients by controlling diabetes better, and by using sensible drugs in a sensible fashion to reduce expenses as well.
Quick public service announcement for everyone watching live. There is a Q&A module. I've got two screens here. I'm pointing to the one that has my Q&A module on it. It's on the bottom left-hand side of your, not bottom left, bottom left middle of your screen. If you hover over your screen, you could see Q&A. If you click on Q&A, you could ask questions to Dr. Dandona through me throughout the session. I'll try to extract questions that are on point with the topic we're covering. And then if they aren't, I'll try to cover them all at the end as time permits. So feel free to throw your questions there. Paresh, very quickly, your camera's definitely a little bit jiggly. I don't know if there's a way to stabilize it or just let go of it, but it's shaking a little bit, just so you know. All right, let's get into the stuff. What are some of the most quick pause here as Dr. Dandona is working on some behind the camera work here. So, Paresh, what are some of the most impactful innovations that you've seen around diabetes treatment and wellness?
Now, this is a very important question, and I think we need to focus on it a little. When I started my center in 1995, we just had insulins.
Hey, hang on, Paresh. There's definitely some background noise that is being created. Some tapping. So I just want to, in case folks are having trouble hearing you, I want to interrupt and see if we could correct that.
Right. So let me see if I can do something better.
Stay tuned, folks. Live TV, live video.
Right. So is that any better?
Yeah, that's better. Why don't we go with that?
Right.
So we're on innovation.
All right. So, as I said, when I started my center here in Buffalo in 1995, we just had insulin, and we had with it sulfonylureas. And then in 96, metformin came along, which had been there in Europe for 2 decades earlier on, and then followed thiazolidinediols or TZDs, and then followed GLP-1 receptor agonists, and then came the SGLT2 inhibitors and so on. So the last 2.5 decades have been full of innovation. And the innovation has been unique and has included compounds that we would never have imagined in mid-90s. So we are blessed with a whole lot of pharmacological preparations and drugs which are very effective and have implications beyond just blood glucose control. And if now we learn how to utilize them sensibly and in sensible algorithms, we will not only prevent complications by controlling diabetes better, we will also reduce expenses. So this sort of united vision has been a part of my aspirations over the last 2.5 decades. And hopefully during this conversation, we'll get on through them. So to start with, it is now accepted around the world that metformin, whose actions keep getting revealed even more and more as we go on, it's a great drug. It does not cause hypoglycemia. It reduces A1C by 1 to 1.5% at the full dose of 2 grams per day. And that's the starting drug in the treatment of type 2 diabetes today.
What category of drug is that? For the
that is called a biguanide, but since it's the only biguanide, it's not worth remembering biguanide as metformin, because its father, fenformin, was thrown away for the simple reason that it used to cause lactic acidosis as a complication. So we don't use fenformin at all. Metformin is the only drug.
Dr. Dandona, are you there?
In this, yeah. And so metformin is the baseline, apart from lifestyle changes, control of diet, exercise, etc., etc. Now, the next drug to use in my line now is something called Pioglitazone, which is a thiazolidinediol, also called TZD for short. And what is interesting about Pioglitazone is that it is not only an insulin sensitizer. We discovered in my lab years ago, and now it's accepted, that it has anti-inflammatory action. And with it, it is cardioprotective. So the recent IRIS trial showed that it reduces the chance of heart attack or a stroke by about 20 to 25%, which is amazing for a drug that does not cost very much. And a similar cardioprotective effect has also been described for metformin. So these two form the basis of my treatment of diabetics before I move on to anything else. Thereafter, I might use a small amount of sulfonylurea, and glimepiride is my favorite one because at a dose of 1 milligram, it gives you significant HbA1c reduction, doesn't cause any hypoglycemia at that dose, and its effect lasts for 24 hours. And thereafter then, I go on to the more recent drugs, which have profound effects of their own beyond just blood glucose control. So the next class is the GLP-1 receptor agonists, of which exenatide was the very first one, which came into the market under the name of Byetta. And then its weekly injection preparation was created, which is called Bydureon. And then came liraglutide or Victoza, which was a daily injection. And then came more recently semaglutide, which is the most potent drug in this class and reduces an A1C by around 1.8%. And even half the dose, half a milligram, will reduce the A1C by about 1.3%, which is similar to the other GLP-1 agonists in existence. And the only one that I forgot to mention, dulaglutide or Trulicity, also is there, and it reduces A1C by about 1.2, 1.3%. all of these have now been shown to be cardioprotective and to reduce the chance of heart attack and a stroke. So that's an added benefit. But then, as I mentioned, the previous drugs, the now out of patent inexpensive drugs, are also doing that. So there is no reason to get started with this class before you started with the foundations with the previous drugs I mentioned. And the last drug now that has come onto the scene and is causing a tremendous amount of excitement again is a class called SGLT2 inhibitors. And these drugs induce your kidney to excrete glucose by blocking the reabsorption of glucose in the renal tubules and the kidney tubules. And by so doing, they reduce blood sugar. But beyond that, quite unexpectedly, we now find that these drugs protect you if you have a history of heart failure, or you have a tendency to develop heart failure, or you actually have heart failure itself at that time. And these drugs are probably now going to be the most important drugs for heart failure. And they have been shown to be effective both in diabetics and in non-diabetics. We are still struggling with what the mechanism underlying this benefit is. But as you can see now, we have profound ways of controlling diabetes. And just to give you a further idea that since diabetes is a cause of heart attacks and strokes, and since atherosclerosis is dependent upon blood pressure and high cholesterol as well, control of cholesterol and blood pressure also becomes an important element. And after all the trials that I mentioned to you previously, there came a Steno trial. Steno is the oldest diabetes hospital in the world. It's older than Joslin Clinic by about a dozen years, started in Copenhagen soon after the discovery of insulin in 1921. And they have been leaders in clinical research in this area. And the Steno 2 showed beautifully that in addition to blood sugar control, if you control cholesterol and blood pressure, you can reduce episodes of not only diabetic complications, but heart attack and stroke. And the overall improvement is by more than 50% over a period of 8 years. So clearly, all of this has got to be thought out comprehensively, and we need to attack diabetes and the related issues of heart attack and stroke by comprehensively controlling all of these issues. And briefly, the algorithm that I work with, metformin, pioglitazone, a tiny dose of glimepiride, and then add a GLP-1 receptor agonist, especially if there is a history of previous heart attack or a stroke, or an SGLT2 inhibitor if there is a history of heart failure. But by so doing, we can cut out complications dramatically. So just to give you an idea, we started this R unit in 1995. By 1997, we had eliminated major diabetic foot ulcers, major gangrene or amputation. We've not had a single major amputation for the last 23 years. And as far as end-stage renal failure is concerned, since 2001, we've not had it if you come to us with a sort of GFR, which is an index of kidney function of 30 or more.
Wow. Let me just for a second, for those of us who don't have deep scientific backgrounds, let me summarize what I think I heard for the folks who are listening to this and want to better understand the innovations around medical care in this disease area. You talked about 3 different areas of new drugs, or at least effective drugs, if used in the right in formulary or right combination. One's called TZDs. This is for type 2 diabetics, and it lowers the resistance to the insulin and reduces the risk of heart disease or heart attack and stroke. So that's number one, you said at the beginning, and you mentioned specific drugs. Then you mentioned these GLP-1 receptor agonists.
That's right.
And they produce more insulin from your own pancreas. They suppress the glucagon, and they suppress the appetite. and which could lead to weight loss, of course, and then it reduces the risk of heart attack and stroke. And then the third area you mentioned were these SGLT2 inhibitors, and they make you lose glucose through the urine, so you reduce your blood glucose levels, and they also protect the heart. Especially, this is potentially the main therapy option for those being treated for heart failure.
That's right. And now we recognize that heart failure probably is the commonest cardiac complication of diabetes. We used to think that it was largely heart attack, but in fact now we know that even without a heart attack, you can go into heart failure with diabetes because of the metabolic abnormalities in the heart muscle.
Okay, I'm going to actually grab a question from the audience.
Yeah.
Because I think it's on point where we are. Alexandra asks, what are the best ways to control high blood sugar readings upon waking, consistent high levels upon waking, even within range at bedtime?
Right. So the way to control weight and control blood sugars at the same time is obviously the simplest part is controlling dietary intake, controlling carbohydrate intake. That's the obvious one. But it's very tough once you're in the habit of eating things and doing things and so on. So in this class, the latest two classes of drugs would be very useful. In other words, the GLP-1 receptor agonists, as you yourself just mentioned, that they suppress appetite and therefore they lead to weight loss. And actually, there is a drug called Saxenda, which is the same thing as liraglutide or Victoza, but in a larger dose, higher dose, 3 milligrams. And that will give you a steady weight loss through appetite suppression. There is also something interesting that we recently showed with liraglutide, published only last month, that when you lose weight with liraglutide, you lose selectively your body fat. You don't touch your muscle. You don't touch your lean body mass, which is a remarkable thing because when you put yourself on strict diet or you get bariatric surgery for weight loss, you lose both your adipose tissue, fat, as well as skeletal muscle, which is not a good idea. So we are now thinking about organizing studies to see whether with bariatric surgery we can provide these drugs to preserve body's muscle, because that matters. Now, the SGLT2 inhibitors also, by causing glycosuria, loss of glucose in the urine, will lead to caloric loss, and therefore they also cause weight loss. So both of these agents, fortunately for us, also cause weight loss. And therefore, if you're looking for a strategy in diabetes where you control blood sugars as well as your body weight, then apart from lifestyle change, these would be the two classes of drugs to think about.
Okay, one more question, and then we'll move on. So Glenn asks, what do you think about programs that use ketogenic diets to reverse type 2 diabetes?
Right. Now, the first thing to mention for any dietary program, including the ketogenic diets, is they're all very tough. You know, people with their enthusiasm can do it for a month, 2 months, maybe 3 months. And then the sad part is that after that hardship, hard work, if you don't sustain that, your body weight bounces back. So it doesn't matter which way you lose weight, because it's going to help your diabetes. It's worth doing it. The only situation where I'd put an exception for that ketogenic diet is type 1 diabetes, where diabetic ketoacidosis is a complication. And the last thing you want is to produce excessive ketones, because you'd be vulnerable to diabetic ketoacidosis. So, but then remember that this class of diabetics is only between 5 to 10% of the entire population. But it's worth keeping in mind that you don't give advice about ketogenic diets to type 1 diabetics.
Very good. All right, so let's move on to like your program specifically. And for those of you who are unfamiliar with the acronym CDE, stands for Certified Diabetes Educator. And so the background here, correct me if I'm wrong, is long waiting period to see you, 6 months or more.
Yeah.
PCPs doing the best they can, but really need to be better educated. And you need to figure out how to get more scale in your program. You're only one person. And what do we do with all these folks who are uncontrolled and in the queue for 6 months waiting to see you? And you need to think of a way, necessity is the mother of innovation, right? So you came up with a program. So let's talk about your CDE program.
The situation of long waiting lists, I thought of the idea that one of my CDEs, I had two of them, I was fortunate, excellent, both of them, but one of them had some spare time. And therefore, I advised her to set up a little mini clinic of her own where she would see the patients on the waiting list.
So Paresh, could you just quickly define what a CDE is so folks who aren't familiar with the training in the background so they know?
Is for Certified Diabetes Educator. So these are usually either nurses or dietitians or pharmacists who are focused on diabetes, and therefore they undergo training to become CDEs. And they have to be under training for around 3 years, and then they can take an examination and get certified. And once they're certified, they can practice as CDEs. And most diabetologists in the country will have some CDE either in their own office or attached to them. But out there in the community, there is a shortage, both of endocrinologists, diabetologists, as well as of CDEs. So anyway, these CDEs trained and working with us then set up this little mini clinic that I was talking about based on the waiting list patients who would be seeing me over the next 6 months or so. And when Margie, my CDE, doing this, started treating these patients for the lifestyle, which she was an expert in anyway, but in addition, what we did was to constantly advise her about drug changes in the patients that were referred to her. These patients were still not under my care. They were still under the care of the primary care physician, and Margie was taking my advice about drugs and advising the patient, and then getting the permission of the primary care physician for prescription of these drugs. And this arrangement led over a period of 6 months, because we analyzed the data and did an audit, that within 6 months, Margie had managed to reduce the A1C by 1.6%, which at that time was better than any drug. In addition, she was also managed, without actually changing cholesterol or blood pressure medications, by just compliance, inducing compliance amongst the patients, their cholesterol and blood pressure as well.
So the standard's typically what? 0.2 to 0.5, right?
So standard performance is 0.2 to 0.5. That is in published literature.
And Margie 0.6 is better than 3 times that.
Yeah. So I'm really, really very pleasantly surprised and felt very proud of this arrangement.
And remind us, how many times were they interacting and engaging with the patient?
These patients were seen over a period of 6 months for 2 to 3 times.
Oh, so not much at all.
No.
Okay.
But again, this is the other point I want to make. The intensity of the message and the way it is delivered matters enormously. Now, for example, one of the common terms used by diabetologists and primary care physicians is that so-and-so is non-compliant. The term non-compliant is banned in my unit. My line is, if your advice is worth following, why should anyone be non-compliant? Patients don't come to you for being non-compliant. It is that you need to do things with intensity and with passion, and good things will happen. So these girls were doing it that way. And when we presented these data at the annual meeting of the CDEs in New Orleans 4 years ago, both of these young ladies got standing ovation for the work they had done. So then that gave me further confidence that clearly the whole arrangement is appealing and that I should see how I can propagate that into the community. So I got in touch with the two medical insurance agencies in Western New York, Blue Cross Blue Shield and Independent Health. And Blue Cross Blue Shield lapped it up immediately. And for the last 2.5 years now, I've had 4 CDEs employed by Blue Cross Blue Shield who report to me every Friday and tell me about the cases they've seen, the problems they've encountered, both on the side of the patient, on the side of the PCPs, and we get on with it and we work with it. And what has happened, and we recently analyzed the results, and it turns out that all those patients who've been following the CDEs have had a reduction in A1C by more than 1%, which, according to the UKPDS study, will tell us that about 1/3 of the complications will be lost. And about 70% of the treated patients got A1Cs less than 7%. So clearly, the process is working, the system is producing results, and of course, with the reduction in the long-term complications, there's also another aspect, that the number of hospitalizations and visits to the ER are also markedly reduced.
So could you just, I want to try to kind of summarize all of that and how that all is happening and how that success is being generated. It sounds like you need to have 1 or 2 really good CDEs with a endocrinologist oversight for medical management. The CDEs are both have to be effective at interacting with the individual patient, being very inspirational and upbeat and positive. It sounds like positive reinforcement is important. And then also they need to be interacting with the primary care physician as well, correct?
Yeah. Yes, absolutely. And that can be tougher because the patient knows that the CDE knows more than him. But the PCP often does not accept that the CDE may know more about diabetes than him. But one has to say that the innovations, as I said, in the last 2.5 decades have been so profound, and the implications have been so profound, that even diabetologists may not know everything that they need to know about these new drugs. So at the PCP level, it's much, much more difficult. He's got to handle, all kinds of disease. He's got to handle bronchitis, vaccinations, obesity, and so on and so forth. Whereas we are talking specifically about diabetes, and we are talking about these nurses who are our agents, who are well-versed in diabetes, both in terms of lifestyle and in terms of drug therapy, and they're constantly under our support and guidance to do the right thing.
Okay, so we got really good CDEs with positive reinforcement. We need really good medical management. We need to gain buy-in from the primary care doc, and we need to promoting better diet.
Yes.
So I want to get into how to build a program like this and what are the key pillars to a program like this. I also want to get into what a reduction in A1C of like 1.6% that your clinic has realized, that your CDE program, has realized. What does that mean to costs, right? How does that translate to dollars and cents as far as payers go, or just any business goes? Before we get into that, I just want to make a pause. One, remember Q&A module right there. I know, Wayne, you asked about financial outcomes. We're going to get there. Put your questions in. We'll integrate them into the conversation. A quick public service announcement. One more. At about 1:45, 1:50, you're going to be receiving another email from me with the feedback form that we send to everyone during any live event that we do. Please check your email, provide us with your feedback, how we can be better, what are the topics you want to cover. This is how we drive our programming and best serve you. We always want to earn your 60 minutes each and every time we invite you to an event. To that end, you guys have given us some great feedback on a concept we've been floating around called an innovation showcase, and we're actually going to do it. So what an innovation showcase is, if you're new to us, is we're going to be putting together in different technology categories, different leading and cool vendors in, let's say, scheduling and patient engagement. And we'll be inviting hospitals and health systems to join the showcase and join us for a half day. We will bring to you 3 to 4 providers of innovative solutions in that category, and they'll present to you in a very concrete, produced manner in 30 minutes, take your questions, and then we'll break, and then you'll get to see another vendor. So in just a half a day, you'll get to see 3 or 4 vendors, save yourself a lot of due diligence and time. And we're going to invite your entire team to come. So if you're a hospital and you join this showcase, we're asking just for a contribution of $299, and you could bring 20 people to it to view and engage these vendors. And you'll have other hospitals in other areas of the country also there who you could also learn from and discuss the vendor's presentation with. So it could be a very cool session. We've asked a lot of you about it. We've been working on it for a couple months. So mark your calendars. I'm going to give you the dates right now. October 21st, we're going to feature the patient scheduling and engagement solution providers. And then on November 4th, we're going to feature remote patient monitoring providers, mostly in primary care and cardiology. And those will be from 1 to 4 o'clock on the East Coast. So both sessions are for provider organizations. If you want to register, you could come to our website, sharedpurposeconnect.com, and you could check it out there. You could also provide us feedback if you want to get information emailed to us by just filling out that little poll that Sherry, our lead producer, threw up on the screen there. All right. So Paresh, let's talk about what is the CDE program, how does it work, and what are the components or the pillars? Let's create a roadmap for everyone who's taking notes and listening in here.
So I described to you as to what we've done. We've approached Blue Cross Blue Shield, and they initially engaged 2 CDEs who were trained by us, both in terms of theoretical diabetology and in terms of practice, because then they worked with us for about 6 weeks in our unit to see what we exactly do with us. And thereafter, they were let loose into the open world, and they went out into the community to introduce themselves. And of course, now they're reasonably well established. And in fact, Blue Cross Blue Shield are actually propagating what they have achieved through to other organizations. But anyway, the important part is that these ladies get to the primary care level, take the permission of the PCPs, get in touch with their patients, and those who have uncontrolled diabetes or high A1Cs, they get referred to them, and then they start tackling them and get back to me every Friday to tell me what problems they've encountered and as to what would be the best way of doing it. And now over the years, they become experts themselves. So their reflexes are very similar to ours, and they do that. The other question that you had asked me earlier was, what about cost savings? And that's an important one. So Blue Cross Blue Shield's own data show that if you reduce an A1C from greater than 9 to less than 7, which is where we try to get every...
One more time, from 9 to 7, you said?
Greater than 9 to less than...
Okay, so roughly 2 to 2.5% total. Yeah.
And you are under 7%, where the chances of complications are minimized. Still can happen, but minimal, according to the UKPDS study and other studies since then. And so you reduce the expense of an average patient by 1/3 by doing that.
Wow.
Which is, yeah. And then if in addition, you have followed my kind of algorithm of treatment, using the inexpensive drugs first before going on to the more expensive ones. The data from Independent Health show me that on my suggestions, within the first 6 months, they had saved $1.2 million.
Wow, that's impressive. Really impressive.
Of the expense of the new drugs.
Just in drug savings alone, not even ED visits, not even hospital readmissions, anything. It's just
drug expense alone.
Wow.
And we calculated, we projected it, that if everyone was to follow my algorithm, in this case of Independent Health, where they're spending about $32 million a year on drugs, it could be reduced to about $2 to $3 million. So tremendous difference. And this is why I like the idea that we should propagate this with passion, with dedication, because you'll achieve 2 end results. 1, better control, less complications, happier, secure patient, and on the other, a happier insurance company saving a lot of money. And of course, nationally too. I mean, Medicare and Medicaid would save a lot of money if we follow those lines of treatment.
Okay, so since we're at the, let's break this down for everyone. First of all, how much does a CDE, give or take, cost generally? I know you're in Western New York. You'll have a different sort of.
An RN starts, a registered nurse starts at around $35,000 to $40,000 a year.
Okay, and how high do you think it could go?
So my Mary, who's been with me about 30 years now, is at about $80K.
Okay, so if we said between 40 and 60, that seems to be a pretty good.
That would be the reasonable.
Okay, and for a program, how many patients does a CDE able to handle in a year?
So
A month. Let's use a month here.
On a day, she can handle about 8 patients, 1 patient an hour. So that makes it 40 patients a week. And that makes about, 2,000 patients a year.
2,000 patients a year. Okay.
2,000. Yeah. And of course, if you give 3 or 4 visits to every patient, then you can divide that way.
Okay, so if that's the case, we're
So
looking at 50 to 60 patients.
About 5 patients well managed every year.
One more time.
About 500 to 600 well managed patients every year.
Very good. And if we're reducing them, and then you could add a part-time medical director, maybe at 50K, very part-time. And then you're talking about, okay, you got your part-time medical director, you've got your, roughly, maybe we'll call it $100,000 worth of CDE salary, and you're able to potentially see between 200 and 240 patients per month, it looks like, if I'm doing my math right. So that's over, like you said, over 2,000 patients in a year. And if you're able to just reduce their A1C reduction of 1% usually means what, a third of reduction in complications?
That's right. Yeah.
And so back at, that could be significant, well over $1 million in savings, as you said. So we could,
also the quality of life of a patient.
Yep.
And you can't imagine how grateful those patients are. And I'll tell you something. Some of my old-time patients who come to see me, if they've not seen Mary that day, they say, "Oh, we've seen you, doc, but where is Mary? We want to see her," because
right.
their own relationship with these people.
So let's outline everything we've covered about how the blueprint here on how to build this. You need to hire the right people.
Yeah.
You need to train them. You have to have a good training program in place.
Yeah.
We didn't talk about how do you get your team to be so, maybe it's just finding it, but how do you get them to be so inspired and so enthusiastic? What do you do there? Is it just picking the right people? Are you showing?
This is where the leadership issue comes in. You got to sow the seeds and you got to, nurture the plant. So just to give you an idea about training, when I came to Buffalo, there was nothing here. I called it an academic desert. And that's the reason I came, because I could see that I could do whatever I wanted to without any interference. And we started a fellowship program in endocrinology from zero. Now this fellowship program is the largest in the country, same size as Mayo Clinic. Mayo Clinic has 54 endocrinologists, I've got just 7. But the passion with which these fellows get trained is quite amazing. About 70 fellows have now, over 72 fellows have trained in our program and are all over the United States, and some have gone back to India. And wherever they are, they've got their own flags by providing leadership. And just not a vain statement, but there's a fact that 2 of my fellows who graduated last summer, a year ago in June, because June is the time they graduate. One of them is in Brooklyn in New York. The other one is in Yuma in Arizona. And what they're telling me is that once they arrived there and they started doing their work, the senior endocrinologists are trying to copy their ways, which to me is so genuinely sort of satisfying and making me happy because clearly the system is working.
That's tremendous. Could you you haven't touched upon data yet. How are you using data to allow your CDEs and you and your endocrinologist to work? How are they leveraging data in Yuma and Brooklyn? And are you getting involved with CGMs or anything like that? So let's talk about data.
CGM is a routine thing in any endocrine practice. And because continuous glucose monitoring, on the one hand, relieves you from multiple finger pricks every day, and it gives you a blood sugar reading every 5 minutes. And it's not only there for a record, it is a tremendous positive feedback for the patient. It acts like patient's extra conscience. So every time a patient does something, he can see what blood sugars are like. So what kind of foods do what to me? What kind of exercise does what to me? And all of those issues come in. And this makes our education piece much more simple rather than guessing as to what would have happened. Now, just to give you an idea, the time that I started in 1975 as a fellow in endocrinology in London, UK, an average diabetic patient had his blood sugar measured the time that he visited the diabetic clinic, which was once in 3 months. So guess, once in 3 months, you had a blood glucose measured. And then the results were not immediately available. I would have to phone the patient. And then the patient would say, well, you know, blood sugar of 230. So what does that mean? And the real answer to that is, I really don't know, because I didn't know that blood sugar is rising, falling, what? So things have, in those days, we used to manage diabetes on the basis of urinary glucose, because that could be measured. So now you have the sophistication of continuous blood glucose monitoring with a blood sugar reading every 5 minutes. Complete transformation. So we really have tremendous, so not only in terms of tracking diabetic control, but also, as I said, in terms of the instruments with which we can reduce the blood sugars, i.e. the drugs. So in my view, not one type 2 diabetic today should have an A1C greater than 7 because we have the means available.
Hey, Paresh, I'm going to grab a question from the audience. Margie wants to talk about how depression and diabetes is being managed, and how are your CDEs trained to offer support there, whether it be directly or through referrals?
Absolutely superb question. So when I started my unit way back in 1994, 95, time and time again, and even now I see that these patients would be depressed. Not only would they be depressed, they would be full of sense of guilt, because the doctor is telling them, you're not controlling your blood sugars, the wife is after him, the kids, if they're old enough, they're also, Dad, why don't you look after yourself properly, blah, blah, blah. But they didn't realize that this guy is really under tremendous pressure, and the drugs are not there, or the means are not there. And these guys would come to me. The first time I would see them, their head would be hanging down in shame. They won't even look at me in my eyes. And then as we controlled their diabetes and the blood sugar improved, and they thought, yeah, it's a logical disease. I can actually look after it if I do it the right way, since I'm now being told the right way of doing it. And then their heads would rise. By the third or the fourth visit, their head was high enough for them to look into my eyes and do that. And I used to call it the sunrise phenomenon. And you know, and it used to be a matter of pride for me, and it still is. And you see this all the time. So depending on the guidance, depending on the therapy, you can transform people's lives, their attitudes, and the whole works. And depression is part of that. So I believe that a majority of the depression is because of the lack of control, and B, the guilt of inability not to control. If you change that, a lot of the depression disappears. But there may be other, endogenous depression, which may lead to bad habits and to diabetes. And that is much more complex. But again, these CDEs are so good and such a humanistic approach that they can often take care of that too.
I'm getting, I don't know if you have this, but some people are asking, God, there's all different questions. All right, for first, the questions directed at you about, it would be great if a list of the studies that you're referencing could be sent out. Do you have anything that references some of these studies? If you don't, it's fine. Do a map.
I have a document which I prepared for Independent Health, and I also sent to the Blue Cross Blue Shield, which lays out the rational plan for treatment, and references can be found in that.
Well, if you were kind enough to send it to me, we'll send it out to everyone.
Will do, certainly.
Very kind of you. So I think that covers the, yeah. And also, so two people have asked me, I could try. So what I'll do, Dr. Dandona, if you don't mind, I'm also going to email you that back of the envelope ROI numbers we were just talking about. And
right.
if you think they're directionally accurate from what you said, I will then edit them and get them out to everyone. A few people are asking for those as well, which I'm encouraged by. That means maybe they're considering doing it. So I'll do that. I'll have Dr. Dandona take a look at it, and I'll send it to you guys in a Google Doc. I'll also take my notes. I know people are asking about, if we could send some highlights. I'm taking notes right now. I'm typing them in that screen. I'm writing them down here. We'll try to get them together. I know Sherry Keels is as well. We'll try to get you some of these highlights as well. 10 minutes to go here. I want to talk about what you would do differently if you were to start all over today, because I think that's really important for those who are sitting on the call right now thinking about bringing a program to their organization. What would you do differently?
Eric, nothing in life is perfect. You always try to get to perfection, but nothing is perfect. So we all make mistakes. We stumble, fall, and then we stand up again and start moving again. And so this journey has been similar. And so, but the important part is really commitment. First of all, knowledge. Second, commitment. And then action dependent on that commitment. And time again, that will work for you. But I personally would not change anything that I've done, because I've been trying hard right from the beginning. Although everything may not have worked, but eventually, once you try hard enough and you're committed and you're doing the right thing, it's bound to work. And you can see it's working.
What would you do about, so I like the pillars, right? Strong training and mentorship program. Okay, check. What about getting the financing in place? How do you, when would you advise everyone who's considering this to get like the health plans or the government involved?
So now I was fortunate enough to hit the right receptors with the Blue Cross Blue Shield, and the movement has grown. And now Independent Health are also thinking of employing these. But on the other hand, Independent Health did something else which was intelligent, following my advice. They had a CDE who was a pharmacist who has been going into primary care practices and has been propagating my line of treatment. And it's largely through her her efforts, that in the first 6 months, we ended up saving $1.2 million for Independent Health by changing physicians' practices and not using. Now, the particular drug that I'm talking about, which is expensive, is a class called DPP-4 inhibitors. And I didn't even mention that deliberately, because they are no better than sulfonylureas in terms of blood sugar control. In fact, they are not as potent as sulfonylureas, and they don't have any cardioprotective effects. So I do not use them. In fact, I take patients off them and replace them by GLP-1 receptor agonists. So there are many things that can be done, and I can, be available for anyone who wants to ask more detailed questions, because really one of my passions is to change the shape of diabetes in this country.
So you got lucky with the plans, but obviously they would have to be part of a program like this. You have to have strong people in training.
Yes.
What about journaling? You haven't mentioned that yet.
So what is sorry?
Journaling, how your CDEs and journaling and documentation, anything that has to be in place there that you think has been especially effective?
So really, no, I think it's the whole program as a package that is working. And I've been fortunate in that one of the major insurance company in this region has taken it on, and they are providing me all the background support as well.
Are you able to showcase to them and your new employees the case studies and the success stories you've had in the past? Like how do you capture those and use those to inspire?
I have now done with Blue Cross Blue Shield is to induce them to make a whole list of all the patients sequentially that these ladies have seen, and to create a compendium and put it on the net for people to see and to experience what kind of struggles they've had and what kind of successes that have followed.
Okay, I'm going to take a question from the Mark. He asks, how can these components be applied to other chronic diseases?
Yeah. So again, entirely, you see, one of the advantages of diabetes is that your indices are measurable in numbers. If you have a measurable index, i.e. A1C and blood glucose and cholesterol and blood pressure, these are all measurable in numbers. And the patient knows them, physician knows them, the CDEs know them, and so on and so forth. Then I think it becomes easier. When you're dependent upon just vague comments of I'm better, I'm not better, things are better, not better, then you are stuck.
Mm-hmm.
So in that sense, I've been very fortunate with diabetes where everything is measurable in numbers. And whichever condition you're working with, if you can numerically define the degree of control, then this system is applicable. Now, for example, asthma is another one. And in fact, I've done some studies with respiratory physicians in asthma. In asthma, if you give a patient a way of doing measuring peak flow meters, these are called peak flow meters. And if you give a patient and he maintains a diary, then you know exactly where that patient was asthma-wise every day. But even that is not being done sufficiently by the respiratory physicians. And I'm surprised, because that's the way you could titrate your treatment. That's the way you could change your treatment, because then you have objective evidence in your hands. And this is what I was trying to do with the asthmatics when they came to me for certain studies, because we were looking at the possibility of improving them.
Yeah, I love this component for all kinds of diseases, and that's a great example. I see we're ending at the top of the hour. I want to be sensitive to everyone's calendar. So a couple of quick housekeepings. If you want to stay in touch with Dr. Dandona, remember, we're going to send you the information he's going to send us. But if you want to connect with him directly, he can be reached at dandona@buffalo.edu. I posted his email on the chat there, so you could see that. I know some of you have asked about that. So dandona@buffalo.edu. If you're listening to the recording of today's episode, right now everyone here is listening live, but when you listen to the recording, it is Bright Spots in Healthcare. It's on every podcast app you could imagine. If you're listening and you enjoyed today's show, please rate it with 5 stars, leave your comments. We're looking for as many testimonials as we could get. If you haven't yet subscribed to Bright Spots in Healthcare, please do so. Every one of our live shows goes into the podcast feed, so you could re-listen, listen again, or if you miss things, catch the times when you can't be here live. I want to thank the entire production team behind the scenes, Sherry Keels and the entire team for helping make this all a success. Thank you all for listening. We value so much the 60 minutes of time that you give us. And last but not least, thank you, Paresh. Thank you so much. I know you're really busy, and the time you took to prepare with me and the time today, really invaluable, really.
Oh, you're most welcome, and I enjoyed it too. So
Thank you. Thank you. And let me know if I could return the favor, and we'll get you, once you get me that information, we'll get it out to the crew, and I'll get those financials out to you for review too. Thank you, everyone. Please fill out those feedback forms. They're definitely in your inbox right now. We'll bother you a lot until you do it. So please save your inbox. This will mark the end of our show. Thank you, everyone. Have a great day.
Thank you.
Take care.
Bye.